In North Carolina, if someone is suffering from severe, untreated mental illness, the most reliable entry ticket to court-coordinated treatment is getting arrested. To be clear, once a person is in the criminal justice system, we have a highly effective tool to help them. Mental health treatment courts divert defendants away from jail and into structured care, reducing recidivism by 42%. Looking at this document, we see the exact numbered steps of how a treatment court works. But look closely at the first two steps. A person has to be charged with a criminal offense to trigger the process, and then voluntarily enter the program. Because of those two strict requirements, the treatment court acts exclusively as a downstream safety net. It is completely inaccessible until the damage is already done. There's a biological roadblock that makes that voluntary opt-in impossible for a massive portion of this population. Between 30 and 50% of people with severe mental illness experience a symptom called anosognosia. Anosognosia is a neurological inability to perceive one's own illness. It is not denial or stubbornness. The brain literally cannot process the information that it is sick, which means these individuals will never voluntarily consent to a treatment court program. Left alone, they fall into a predictable, preventable spiral. They stop taking their medication, cycle through emergency room boarding, face temporary involuntary hospitalizations, and eventually end up in a jail cell. This bar chart compares the financial toll of those two paths. Reactive crisis cycling, relying on emergency rooms and jails, costs upwards of $60,000 per person per year. Coordinated community-based care costs roughly $12,000. Waiting for a mental health crisis to escalate into a criminal offense abandons the patient, and it drains public funds at a 5x multiplier. North Carolina already has a legal mechanism to intervene before a crime occurs. Under Chapter 122C of the General Statutes, a judge can order assisted outpatient treatment, or AOT. This framework shows how AOT bypasses the criminal justice system. The trigger is clinical deterioration. Entry begins with a civil petition. Operating in a civil court means no criminal record. Full due process, including a hearing and counsel, ensures it's a clinical tool, not punishment. If the court issues the order, it mandates specific wraparound services. The patient receives medication management, housing coordination, and peer support, all while remaining in their home. AOT acts as a temporary, dignified bridge. Instead of relying on the blunt coercion of a jail cell, it restores autonomy to people whose illness physically prevents them from asking for help. We have decades of data proving this works. Research from Duke University evaluating programs in North Carolina and New York shows that when AOT is sustained for 180 days or more, the outcomes are striking. This graph tracks the intervention's impact on systemic strain. For patients under an AOT order, psychiatric hospitalizations dropped by 77%. A second line reveals the impact on the justice system, a corresponding 83% drop in arrests. These reductions in emergency and judicial strain are achieved at that same $12,000 annual cost point. When you compare the outcomes, proactive court-ordered community care is objectively superior, both economically and morally, to the reactive cycle of hospitalization and incarceration. These two tools, civil AOT and criminal treatment courts, are not competing programs. They are designed to function together as a perfectly paired closed-loop system. Think of AOT as the upstream guardrail. It sits at the top of the cliff, intercepting patients who lack insight and preventing the crisis from occurring in the first place. The mental health treatment court is the downstream safety net. It sits at the bottom to catch those who still manage to slip through and commit an offense. Even if the upstream guardrail fails, the safety net is stronger because of it. If an AOT patient enters the treatment court, the judge is already armed with clinical data and provider relationships to better manage their diversion. When these two distinct mechanisms operate as a single continuum, the system ensures that no citizen falls through both nets. Building this closed loop doesn't require passing new laws or funding a massive new parallel system. Eastern North Carolina already has the components in place. The community mental health providers, Trillium as the managed care organization, and a bench of experienced district court judges are all operating right now. What is missing is the local leadership required to link these two existing pathways together. North Carolina has the power to build a truly comprehensive system that honors human dignity. We can provide a pathway to care for every citizen, even those whose brains prevent them from asking for it.